Bismillah ar-Rahman ar-Rahim. I'm Dr. Rania Mohammed Bahriz, lecturer of diabetes and endocrinology, Mansoura University. Today, I'll discuss to you hyperparathyroidism and hypercalcemia. First of all, we must know normal serum calcium level, which is from 8.5 to 10.5 milligram, and it is subdivided into ionized calcium and non-ionized calcium. Ionized calcium about 50% and also non-ionized the other 50%. Ionized calcium is the active form which is responsible for the calcium action, while a non-ionized calcium is subdivided into protein bound, which is about 40%, and calcium in bones and teeth. So, what about serum calcium control? Which control the calcium level in our blood, or what affects our calcium level in blood to be from 8.5 to 10.2. There are several hormones which control our calcium level. The most important is parathyroid hormone, which is released from the parathyroid gland. It's also called PTH. How the parathyroid hormone control calcium level in our blood? It acts by increasing the calcium and decreasing the phosphorus. Increase the calcium by its action on intestine, kidney, and bone. On intestine, it increases the calcium absorption through the activation of vitamin D, or its role in activation of vitamin D. In the kidney, it increases calcium reabsorption and decreases phosphate reabsorption. And on bone, it increases osteoclastic activity, which causing resorption or increasing resorption on bone, increasing the calcium level. What's meaning of osteoclast activity? It means that it stimulates osteoclast cells, which is responsible for bone resorption, so maintaining a level of calcium in blood within normal levels. Second, which control the calcium level also, is vitamin D. Vitamin D, which the main source of it is from sunlight. It acts on calcium level or maintaining the calcium level within this range by increasing the calcium from intestine, by increasing its absorption in the kidney and in bone. Also in phosphorus, it increases the phosphorus level by mainly the kidney. In small dose, it causes phosphorus retention. In large dose, it causes phosphorus excretion. In bone, in normal bone resorption, a third most important is calcitonin. It acts or maintaining calcium level within a normal range by decreasing the calcium, by decreasing the osteoclastic bone resorption and increasing renal excretion. On phosphorus, it decreases the phosphorus level in blood by increasing the renal excretion of phosphorus. One can ask me, calcitonin hormone is secreted from where? It is secreted from thyroid gland, but from the parafollicular cells or C cells of the thyroid gland. There are other less important things which control calcium level in our blood, like acid-base balance, glucocorticoids, and the thyroid hormones. For acid-base balance, Any disease cause acidosis increases ionized calcium. Any disease causing alkalosis decreases ionized calcium. And we say before that ionized calcium is the active form of calcium. So if there is decrease in the ionized calcium, the patient will manifest the manifestations of hypocalcemia. Glucocorticoids, if it is increased, there will be decreased the calcium and phosphorus absorption, causing steroid-induced osteoporosis. For thyroid hormones, if they are increased, there is decrease in the bone mineral density and osteoporosis. Also for growth hormone deficiency also will lead to disturbance in calcium level, as growth hormone acts through insulin-like growth factor 1 to maintain a normal bone mass, and also it stimulates or has a role in the stimulation of vitamin D, which stimulates calcium absorption by gut. Then we will talk about hyperparathyroidism. This is the next topic. For hyperparathyroidism definition, it means abnormal increase in parathormone secretion. So we must ask ourselves a question. What is the hyperparathyroidism? It means abnormal increase in the function of the parathyroid gland. Where is type? What is the site of the parathyroid gland? It is present behind the thyroid gland or embedded in the back of the thyroid gland. They are 4 glands which are responsible for the secretion of PTH, which is or has a great role in maintaining calcium within normal levels in our blood. So hyperparathyroidism means hyperfunctioning of the parathyroid gland, leading to abnormal increase in the PTH secretion. So what is the drawbacks of increased PTH secretion? We will know later on. First, what is the types of hyperparathyroidism? It may be primary hyperparathyroidism, which may be sporadic, solitary adenoma from 80 to 85%, multiple gland hyperplasia from 10 to 15%, or parathyroid carcinoma for about 1%. Second, familial. Hyperparathyroidism may be familial, like multiple endocrine neoplasia type 1, which is called MEN, which include also pancreas and pituitary neoplasms, or multiple endocrine neoplasia type 2A, which include also pheochromocytoma and thyroid medullary carcinoma. Also, there is familial hypocalciuric hypercalcemia, which means what? Which means that there is decreased renal excretion of calcium, so there is increased calcium level in blood. So it's characterized by hypocalciuria, mild increase in PTH, and mild hypercalcemia. From the types also, tertiary hyperparathyroidism. Tertiary hyperparathyroidism occurs following secondary hyperparathyroidism. So what is secondary hyperparathyroidism? Secondary hyperparathyroidism occurs in case of decreased serum calcium, which may be due to chronic renal failure or maybe due to malabsorption. So there is feedback increase in the parathyroid hormone. Prolonged or secondary hyperparathyroidism lead to tertiary hyperparathyroidism through development of autonomous adenoma. So these were the types of hyperparathyroidism. What about a clinical picture? The most common clinical presentation of primary hyperparathyroidism is asymptomatic hypercalcemia, which may be detected accidentally during routine biochemical screening. So, if there is symptoms or signs, it will be of hypercalcemia, like renal manifestations like polyuria, polydipsia, nephrolithiasis, nephrocalcinosis, nephrogenic diabetes insipidus, renal tubular acidosis, neuropsychiatric manifestations like stupor, confusion and coma, gastrointestinal manifestations. Most important are pancreatitis and constipation, musculoskeletal manifestations in the form of bone pain, osteoporosis and ostitis fibrosa cystica, cardiovascular manifestations like bradycardia, hypertension and short QT interval. After clinical picture and suspicion of hyperparathyroidism, how to diagnose, or what is the investigations to diagnose a case of hyperparathyroidism? First of all, in primary and tertiary and familial, there will be elevated PTH, there will be hypercalcemia, hypophosphatemia, there may be detection of adenoma in isotopic scanning of the parathyroid gland. There may be detection of ostitis fibrosa cystica, maybe in the form of an epilepsy in the jaw, most commonly found, osteoporosis, kidney stones, nephrocalcinosis, other hormonal assay if I suspect in men. Differential diagnosis of hyperparathyroidism. Clinical findings that favor the diagnosis of primary hyperparathyroidism include asymptomatic patient with mild hypercalcemia, a postmenopausal woman, a normal physiological examination, no other obvious causes of hypercalcemia, no family history of hyperparathyroidism, and no evidence of multiple endocrine neoplasia. And this is the differential diagnosis of primary hyperparathyroidism. Then we must differentiate between primary, tertiary and familial hyperparathyroidism. And primary, as we said, in tertiary, as we said, the patient may be a patient of chronic renal failure or a patient on hemodialysis or patient with malabsorption syndrome. In familial hyperparathyroidism, there may be a criteria of men, or there may be a familial hypocalcemic hypercalcemia. In secondary hyperparathyroidism, it is characterized by elevated plasma PTH and hypocalcemia and hyperphosphatemia in patients with chronic renal failure, and we must exclude other causes of hypercalcemia. Treatment of hyperparathyroidism include lowering serum calcium as a patient has hypercalcemia, and the treatment of the cause if it is primary, so surgical removal of the adenoma, or tertiary and in men, so treatment is surgical removal of the adenoma. Third part of the lecture is hypercalcemia. Hypercalcemia is a relatively common clinical problem. It results when the entry of calcium in circulation exceeds the excretion of calcium into urine or deposition in bone. Causes of hypercalcemia can be classified into causes which increase bone resorption, so causes which may stimulate osteoclast activity, like primary hyperparathyroidism, tertiary hyperparathyroidism, malignancy through secretion of local osteolysis or osteoclast activating factors, thyrotoxicosis. Other less common causes like immobilization as in bedridden patients, Bahriz disease of bone, patients which take anti-estrogen like tamoxifen, and hypervitaminosis A. Increased calcium absorption through increased dietary calcium intake, excessive calcium supplementations, milk alkali syndrome, and hypervitaminosis D due to vitamin D fortified milk or calcitriol in high doses. From the causes also, PTH mediated hypercalcemia like primary hyperparathyroidism, sporadic, or familial like men type 1 and men type 2A, or familial hypocalcemic hypercalcemia, or tertiary hyperparathyroidism. All cause hypercalcemia except is secondary. PTH independent hypercalcemia like hypercalcemia of malignancy, vitamin D intoxication, or chronic granulomatous disorders like TB or sarcoidosis. Medications like thiazide diuretics, lithium, which is used as antipsychotic, excessive vitamin A, and thiopurine toxicity. Other causes like hyperthyroidism, acromegaly, pheochromocytoma, adrenal insufficiency, and this may be the endocrinal causes of hypercalcemia, parenteral nutrition, and milk alkali syndrome. In manifestations, as we said, in primary hyperparathyroidism, maybe asymptomatic, maybe manifestations including the renal system and nervous system, cardiovascular system. But in severe hypercalcemia, when calcium becomes above 14 mg per deciliter, there is often progression of these symptoms. How to evaluate laboratory for hypercalcemia? When we do laboratory evaluation for hypercalcemia, we must do correction of serum calcium for albumin, and an elevated concentration should be confirmed by repeated sampling. Additional lab data may include serum protein electrophoresis for possible multiple myeloma as an important cause for hypercalcemia, and TSH as hyperthyroidism because hypercalcemia will often lead to the correct diagnosis. Also, urinary 24-hour calcium may be helpful in cases of familial hyperparathyroidism. Evidence of ostitis fibrosa cystica on bone films is very specific for primary hyperparathyroidism. Treatment of hypercalcemia, if it is mild, there may be a possible solution is adequate hydration, at least 1.5 to 2 liters of water per day is recommended to minimize the risk of nephrolithiasis. Additional therapy depends mostly upon the cause and treatment of the cause. In moderate or acute rise of serum calcium requires more aggressive therapy as described for severe hypercalcemia. For severe, we must do volume expansion by saline at initial rates of 200 to 300, calcitonin, biphosphonate, glucocorticoids, especially in patients with lymphoma, sarcoidosis, or granulomatous disease, and dialysis for severe life-threatening cases. Thank you for listening.